these are my disclosures. None of them, I think, are directly related to this talk. So when we go back and we look over the last 15 or 20 years, there's really been a radical change in the thoughts as far as how spinopelvic parameters interact with our ability to think about and classify adult spinal deformity. And if you look at this initial SRS classification by Tom Lowe and others, it was really focused on a growth of the King Mo and Lanky classifications, with the thought being that really adult scoliosis in most cases was really a progression of what was seen in adolescent scoliosis. And as you can see, there were some modifiers similar to the Lanky classification for each region, but there was really very little thought given to spinopelvic parameters, except for in this case for the sagittal vertical axis. Well, there was a gradual realization over time that much of adult deformity was really de novo degenerative scoliosis, and the basic underlying process was disc and facet joint degeneration, which resulted in the loss of lumbar lordosis. And what they found was that there was a direct correlation and a very strong correlation between this loss of lordosis, the development of sagittal imbalance, and particularly the recognition that there was if a mismatch developed between the pelvic incidence and the lumbar lordosis, that this was particularly symptomatic. So there was a realization that there were different morphotypes of the spine that was driven in large part by the pelvic incidence. And so if you had a low pelvic incidence, you had a vertical sacrum, and you needed relatively limited lumbar lordosis, or if you had a high pelvic incidence, you had a more horizontal sacrum and had much more need for substantial lumbar lordosis. So this was kind of the initial simplified involvement, and we looked through through some work through the ISSG. There was a realization that some of the major driving parameters involved in adult scoliosis were the sagittal vertical axis as a measure of spinal malalignment, the importance of spinopelvic harmony and the association between the pelvic incidence and the lumbar lordosis. And then finally, as a compensatory mechanism, the amount of pelvic retroversion is measured by the pelvic tilt. And this just radiographically shows some examples of each of these. And again, it was shown to be very highly correlated with health-related quality of life scores. So again, here's another simplified version of these different parameters. And what was found was, in some studies looking at oxygen utilization and other factors, when the spine was well aligned and the spinopelvic parameters were well balanced, the people used little energy to be able to stand in an upright posture, and again showing this relationship. So again, some work that was done through the ISSG showed that there were thresholds that were determined, and basically it was found that people became substantially more symptomatic if their pelvic incidence and lumbar lordosis exceeded 11 degrees, if their SVA exceeded about 5 centimeters, and if their pelvic tilt was more than 22 degrees. But this analysis looked at hundreds or almost, or nearing 1,000 patients. And what's happening is that there was a realization at time that our group probably overly simplified things across the board. But what we found was, again, looking at this, that this allowed us to be able to develop a newer SRS classification, and this effort was led by Frank Schwab. And what it was, something that was relatively simple, and I think that much of these concepts have more globally permeated the spine community. And again, it was a good starting place, but it certainly doesn't take into consideration the entirety of the nuances about what goes on. But this was the Schwab SRS classification, which again looked principally at the pelvic incidence minus the lumbar lordosis, the amount of global sagittal vertical axis malalignment, and the pelvic tilt. And these were some general alignment objectives. And this was something that was written by Frank and Virginia Lafage, and it gave some basic concepts about how the spine should be realigned. And what there's, as you're going to see in a moment, this works very well for young people, for young adults, but it doesn't hold as true in either extremes of alignment or extremes of age. So this was some work done by Justin Smith, looking again at ISSG patients, that showed that if you could go and change the patient who had adult scoliosis and put them to more normal values as dictated by the spinopelvic alignment parameters, that, as you can see, that it resulted in consistently improved health-related quality of life scores for the patients that you did surgery where you achieved those goals. And if you can see that if you didn't achieve the goals, that you're more likely to be unchanged or even have your condition deteriorate. And this is a patient of mine who'd had, that was sent to me after multiple previous surgeries. And you can see that the patient's ODI is 69, showing the patient was pretty significantly debilitated. And you can see after a relatively major 3-column osteotomy and realignment that the patient's ODI is 11, showing that that the patient had almost near age related pain and functional levels. So one of the nuances which was gradually realized is we aggressively treated patients with aggressive realignment, that our rates of proximal junctional kyphosis just began to skyrocket. And what we realized, that trying to put everybody's spine back to what you would find in a 20-year-old or 30-year-old or even 40-year-old was likely over aggressive. And we were also, as you're going to see in a minute, realizing that we're replacing the apex of the lordosis was likely too high. And I know when I first started doing pedicle subtraction osteotomies, a lot of times I would do those at L2 or L3, which is really not where the ideal amount of lordosis was. And again, doing pedicle subtraction osteotomies and other 3-column osteotomies in people in their 60s and 70s likely resulted in overcorrection of their deformity based upon age-adjusted alignment objectives. So one of the things that the ISSG did was started looking at normative values for older patients. And what we found, for example, if you're more than 75 years old, a pelvic tilt of almost 30 is still in the normal range. That a pelvic incidence lumbar lordosis mismatch of greater than 20 degrees is still probably normal, and an SVA of 10 centimeters is also probably within normal and acceptable ranges. So what we realize is what you want to do to a 40-year-old is distinctly different than what you want to do to an 80-year-old. The next thing we realized is that there is a normal distribution of lordosis, and it's not just us, it's the ISSG group. And as you're going to see in a minute by Professor Rousselet, was really one of the people that keenly understood that, you know, lordosis with an apex at L2 is different from a lordosis at an apex at the L4-5 disc. But there was a realization that in most cases, the lordosis usually is, the majority of it is between L4 and S1. And this is some work showing that even in simple cases, including 1 and 2 level fusions for degenerative conditions in the lumbar spine, if you do not get the lordosis in the right place, and you don't, and you're not able to go and to have good spinal pelvic balance, that the consequences of it are pretty high. So this was looking at 1 to 3 level fusions, and what they found was if you had a good match between your pelvic incidence and your lumbar lordosis, the likelihood of adjacent segment disease and the need for revision surgery was quite low. If you had a significant mismatch, it was quite high. And so other studies, this is some work out of University of Pittsburgh, showed that if you had a PILL mismatch of more than 11 degrees, that this was associated with a 75% likelihood of developing a symptomatic adjacent segment disease. So you can see here, the worse the mismatch, the more likely you had adjacent segment disease requiring revision surgery. And you can see conversely, if you had good overall alignment, the number of revisions that were needed were actually quite small. And this is, again, some additional information showing exactly the same thing, that getting good alignment is important for both big surgeries and little surgeries. So the next thing that we realized, looking at, again, hundreds and hundreds of patients, is what the ideal alignment for, even for younger people, varies a bit. And what happens is a lot of stuff is based upon averages. And the average, pelvic incidence is around 55 degrees. And what was found to get the best results for surgery, if you had a small pelvic incidence, you wanted to get a bit more lordosis. So, for example, the most ideal results were if you have a pelvic incidence of 20 degrees, you want about 10 degrees more lordosis, and the lordosis would ideally be lower in the lumbar spine to get the best results. On the other hand, if you have a large pelvic incidence, in this case about 80 degrees, then you want a little bit less lordosis, and that lordosis can be distributed through the entirety of the lumbar spine, including the mid-lumbar area. So again, this is moving towards personalized treatment of these patients with adult spinal deformity. And again, this is, part of the reason is the distribution of the lordosis, depends upon the discs and depends upon the vertebral body shapes. But overall, you want about 2/3 of the lordosis in the lower lumbar spine. As you can see here, the 66%, 2/3 of the lordosis. So this then led further to work by Professor Rousselet, who described four principal morphotypes of the spine. And what has been shown is, depending upon the morphotypes, which is principally related to the pelvic incidence, those who have low pelvic incidence need to have the apex of the lumbar lordosis in the low lumbar spine, either at the L5 or L4 discs, compared to the people who have a very high pelvic incidence. So you can see on the right where the apex of their lordosis is in the mid lumbar area. And taking all this information together, the ESSG has done a really good job of processing this and coming up with the work, as you're going to see, that is this part of their gap analysis. So again, this is some work again out of the ISSG, showing that, again, depending upon the pelvic incidence, where the lordosis is principal. So if you have a low pelvic incidence, as you can see, the lordosis is in the low lumbar spine. An average pelvic incidence, it's still slightly biased lower, but it's distributed throughout. And high pelvic incidence, again, there's more lumbar lordosis in the mid lumbar area. And again, personalizing this has some real importance, as you're going to see in a minute, particularly as far as the best functional outcome, but also to reduce the risk of complications, mainly PJK. So this is the great work that was done by the ESSG for the GAP score, and it takes a number of different factors into consideration. It takes into consideration the lumbar lordosis distribution index, and how much of it is in the low lumbar versus the mid lumbar spine. It evaluates the relative spinopelvic alignment. It does the relative pelvic version, the relative lumbar lordosis, and all of these factors results in this gap score analysis. And what has been shown is that if you go and you have a well-aligned spine by the gap score analysis, you are likely to have a much lower incidence of proximal junctional kyphosis and failure. And again, even in long fusions, as you can see in this case example from the ESSG's work, you can see that ideally by gap analysis, the apex of the lordosis should be at L4. It was at L2, and that PJK developed in relationship to this occurring. And again, and what it showed is those people who have their lumbar lordosis, where it theoretically would be ideal, had a much lower rate of PJK. This is some work looking at the ISSG, looking at similar factors. And what we found was by restoring lumbar lordosis at lower levels decreases the risk of PJK. So we discussed the importance of these age-adjusted targets, which also, again, is directly correlated with the incidence of PJK. So what we found was that undercorrection on age adjustment alignment thresholds, can lead to worse quality of life, whereas overcorrection gives absolutely no additional benefit and has the consequence of having much higher complication rates. So it's important that you go and you look at the morphology and you look at the age-adjusted criteria to decide upon what has the results. And just as Cal was saying in his very nice talk, the different things such as vertebroplasty and hooks and tethers, they all have a relatively limited effect. But by having the appropriate age adjustment goals, this has a much higher ability to go and to reduce these different complications. The last slides or two, I think that there's been an underestimation of the importance of coronal deformity, and particularly as far as improving and correcting the lower fractional curve at the lumbosacral junction. And what has been shown is that we as a community have generally done a relatively bad job. We're up to 20% of the patients that we're operating on. We're not attentive enough to correcting the lumbosacral fractional curve, and this results in it can result in sagittal imbalance. And this again shows several examples of the importance to be able to go and to correct this to get better improvement. Again, this is a patient of mine with a type C deformity. The importance, again, that this person had a fused spine, so needed a pedicle subtraction osteotomy. And you can see here that this is the patient's fused spine. This shows a couple areas where there's potential motion, but because of the relatively fixed nature of the lumbosacral junction, that the use of a 3-column osteotomy and a kickstand rod to be able to correct all that and to correct the coronal imbalance becomes important. So basically, the principal driver of symptoms in adult scoliosis is spinopelvic mismatch. And there's both individual morphometric and disease-specific parameters that influence the ideal alignment. The impact of coronal imbalance has been underestimated and is something that should be addressed. And basically, if we don't do a good job, our results aren't nearly as good. So taking these different factors into consideration is important. I do, as the president of the SRS, want to welcome all of our friends in Egypt and throughout the world to our wonderful society. We welcome you with open arms. And just to remind, we've had a change that the next SRS annual meeting next September will be in Stockholm, Sweden, rather than being in Sydney, Australia. There's an IMAS meeting this spring, which is planning on having both a virtual and live component in Miami, and then March of 23, the IMAS meeting will be in Dublin, Ireland. So we welcome everyone with open arms to the SRS organization, which I would be happy to help get people facilitated for membership and into our great meetings.